So I started recreationally using marijuana when I was young, probably 15, just for fun. And then when I was 22, I want to say, or 21, I started using it every day as a coping mechanism to deal with a bunch of mental health conditions that I was suffering from at the time, and trauma and an abusive relationship that my mum was in that was affecting me. And for a while, it was good at calming me down, and it still is effective at calming me down to an extent. However, there is a lot of health implications that come along with it that affect me, and even my spirit personally as a singer, as it affects my ability to sing due to lung damage, so, and throat irritation and vocal cords irritation. I'm hopefully going to try medicinal marijuana to get off the thought out in the land. I don't know what to call it. So I can still control the intense anxiety, intense rage that I get whilst not destroying my body at the same time. And I have hopes of the future, and I hope that I can update you with positive progress.
Okay, so Maisie is a 23-year-old patient who first started visiting 5 years ago with concerns with repetitive recurrent headaches. And she had a past history of benign intracranial hypertension. And so she was taking Panadin for the headaches, and later it became a drug-induced headache. So she had a past history of a lot of childhood trauma, and to cope with this anxiety and depression, she had to depend on cannabis. So later it became an overuse kind of problem. And then she started developing tolerance to its use, and then ultimately she became a victim of cannabis dependence. According to Center of Disease Control and Prevention, heavy marijuana use can cause memory impairment, inattention, learning difficulties, and it can alter the lung pathology. So if you had listened to Macy, you would have heard her telling that she had a lot of respiratory problems and focusing issues as well, which had started impacting on her work, her family relationship. And so with a routine treatment plan, she understood the importance of coming off cannabis, and then to cope with her anxiety, depression, her mood concerns. She agreed on trying on the medicinal cannabis. She hasn't started it yet. So why it's important to challenge the myths? Because it's a challenge to treating doctors. So it's important to stop stereotyping. So the National Drug Strategy Household Survey, or the NDSHS, collects information on alcohol and tobacco consumption and illicit drug use among the general population in Australia. According to the NDSHS, 9 million Australians have used an illicit drug at least once in their life, and 3.4 million Australians have used an illicit drug in the past year or so. So this NDSHS survey also studies the attitudes and the perceptions in relation to tobacco, alcohol, and other drugs. So why it is important? Why it is important for the doctors to know about these myths and stereotypes? Because it can affect the therapeutic relationship, because it can impose a negative impact on the consultations when we do motivational interviews with the patients. And it can also lead to medication incompliance and also delay access to treatment. So people develop addiction due to lack of willpower or self-control. So there are so many factors as we saw and mentioned before, like that can influence on addiction. So certain personality factors like impulsive behavior or like sensation seeking or like psychopathology, such as a mental health illness. So they negatively impact on the treatment process, and also like any childhood trauma, like abuse, like which we commonly see in the general practice setup. So that includes sexual abuse, emotional abuse, and also the environment a person grows, the genetic factors, and the social and economic factors, strength of the family and the peer relationships, and the presence of absence of educational and employment opportunities. Even people with strong willpower, let it be doctors even, like could be a problematic alcohol and other drug users. Like we talked about the high functioning addiction. And then as an alternative to recreational sports, right? So like some people like to listen to music, art, but certain people start using this cannabis or like other substances as a sort of a recreational activity. So we all know we are like, not so comfortable prescribing diazepam or like emazepam for our patients. But unfortunately, it's one of the commonly prescribed medication in a general practice setup. Normally, it's prescribed for insomnia, anxiety, panic attacks, even though we all know that it's not the first line medication of choice. The first line medication, or the first line treatment option for anxiety is obviously the cognitive behavioral therapy, a non-medication option. But why? Why it's being done so commonly? Because every time the patient presents, the patient sitting in front of you is like, okay, it's concerned about sleep, it's concerned about a panic attack. So we have no option. So we need to deal with the current situation. So we start prescribing. So when the duration exceeds 4 weeks or more, then it becomes a problem, becomes patient inevitably getting tolerant and like later on becoming like dependent on the medication. So it's very, very important at the very beginning to consider how long we are going to do this. So we need to start the conversation. We need to explain the patient that these are the problems that can happen. So we need to have a plan. So now when the patient is dependent on a benzodiazepine, we have to make sure whether the patient is ready to come off this medication. So that therapeutic relationship is very important, and we have to offer an individualized treatment plan. So every patient is different. So it's the therapeutic guideline advises a 15% reduction of dose like in a week time. So it has to be a very slow process. We need to deal with the withdrawal symptoms because rapid withdrawal can cause a lot of concerns, anxiety, insomnia, like seizures, myoclonic jerks, and it can increase the heart rate and can cause sensory disturbances and neurological features as well, like photophobia, like hyperacusis, increased sensitivity to light and sound. And so how are we going to do? So in addition to this withdrawal plan, like slowly reducing the dose, we need to advise on regular aerobic exercises and regular massage to reduce their muscle pain, and offer like to see them regularly, like frequently as possible, and advise them to maintain a diary, like writing all the experiences, the symptoms while this withdrawal plan. So then there are other few reasons why we should consider this. So it reduces the stigma. So it's important to understand the myths, the stereotypes, So we can like work well with this treatment program. So because it can impact so many people, many individuals, like they find it very hard to continue. And then the treatment failure. So it can worsen the patient's anxiety and depression, even like suicidal ideations. So it causes a negative impact on the family. So family participation, the understanding is very important in a successful treatment. It facilitates the patient-centered management. So it has to be a bilateral thing. So the doctor can't decide on his or her own. So the patient involvement in the management is very important. And it also improves our knowledge and understanding of alcohol and other drugs. And it's very important to encourage the individual to involve in the treatment plan and also help them, support them, searching resources, including tools. So we can help them to understand where they stand, how successful they are in reducing the benzodose or any other substance. And it's important to encourage the individuals about like the addiction and coming off it. So patient fact sheets are very useful in this regard. So you can find these facts sheets in our resource section in the AOD web page. And there are other like the primary health network treatment pathways also a common place to find these fact sheets. Then most of these stereotypes are based on lifestyle. So when you say lifestyle, it's about unemployment, it's about the victims of child abuse or domestic violence, and most migrants have these addiction concerns. And we tend to think that high school dropouts and even prostitutes. So this is the common idea we all share, like, okay, a person with addiction could be one of these, but it's not the real situation. Actually, the NDSH study has found nearly 43% doesn't fit into any of these stereotypes. So the other common myth is like heroin addicts are junkies. So we all know, so we tend to think that heroin drug users are mostly seen on the roads, streets, and often they're overrepresented in jails, detention centers, mental health services. Heroin addiction can result in serious physical and mental health problems. They're very significant. So they can have like cardiovascular problems like stroke, heart attacks, myocardial infarction, and they are at very risk of getting a sexually transmitted infection. And they can experience sexual dysfunction, which can lead to intimate relationship concerns. They can suffer sleep problems, insomnia, and the appetite can be like a low appetite, then depression, anxiety, ADHD, bipolar disorders, schizophrenia, borderline personality disorders, antisocial personality disorders. So drug-induced psychotic features and paranoid ideations, they can have impaired cognition. So overdosing with heroin can lead to toxicity, death, and vomiting. So the symptoms can be like pale, clammy face, changes in the pulse rate and blood pressure. Like the breathing can be shallow and erratic, and there can be like changes in the level of consciousness, agitation, paranoid ideas, and seizures. So the doctor treating this type of individuals who present with these concerns should know when to refer to a specialist. So when there is an unexpected dose escalation, or when the person, it could be a benzodiazepine, not necessarily opioid or any other medication. The upper range of the drug dose is reached, or when there's a suspicion of an abuse or misuse, or when the patient has a high level of distress, or when the patient's risk category has changed, or the patient's comorbid condition, or like for example, his depression's getting worse, or like a psychological disorder is not well controlled, or he requires an unusual opioid dose if he is requesting a particular dose, or if there are any suspicions of doctor shopping or drug diversion, or if there is a risk to the patient himself or herself or to others, then it's important to refer these patients to a specialist, an addiction psychiatrist, or like at least to emergency department. And then LSD, the lysergic acid diethylamide, it's a hallucinogen. It can cause nausea, dilated pupils, tremors, disturbed sense of time, visual hallucinations, psychosis, spontaneous visual distortion, and increase the pulse rate. So these are the common symptoms associated with LSD. LSD use is common, but not common as before. It's not common in teenagers or young adults, but it's still very popular in an older age group, like old adults. And so the important concept here is whether it is addictive. So it causes more kind of a psychological dependence rather than a physical dependence. So one of the common myths is like alcohol makes it easier to socialize. In today's digital age, social media and alcohol have become very like an intertwined thing. So alcohol-related advertisements and marketing encourage people to drink. So even like in young adults, so they tend to impose this idea like that small quantities makes feel you relax, and it's okay to drink in a small quantity and in a social point of view as well. And the large quantities create embracing moments or aggression. But it's not true. Even like a small quantity still like can make you more physical and mental harm. So the myth is it is safe to drink after cannabis use. This is another common myth. So obviously not. Reduced focus or concentration, and it also reduces and impacts reflexes and coordination. So it is not okay to drink after cannabis use, and especially in pregnancy. And then about methamphetamine. Meth is made in a controlled lab environment. So some people with addiction concerns tend to think that it is okay to have. It is quite safe, like because it's made in a controlled lab environment. As you all aware, it's a highly addictive stimulant sold on the streets under several names. And crystal meth is white powder. It's an odorless, dissolvable in water. So it causes a lot of short-term effects and long-term effects. The short-term effects, like it increases your energy level, and like you can have like more attention, increases attention and alertness, increased talkativeness, increased state of well-being or euphoria, and it reduces the appetite and increases the muscle tension, particularly the jaw clenching and teeth grinding, nausea, vomiting, dry mouth, changes in libido, nervousness, anxiety, paranoid ideas, aggression, violence, chest pains. And the long-term effects are like mood and anxiety disorders, cardiovascular problems like heart, myocardial infarction, hemorrhagic stroke, poor focus and concentration, and paranoid ideas and hallucinations leading to psychosis, substance-induced psychosis, and weight loss. So the effect of the crystal meth can last up to 12 hours. So the myths related to this are like legal highs are safe as they are legal. The logo in a pill is a good indicator of its efficacy. So that means like if you have a pill with a logo on that, that is safe to use, which is obviously not. And another common myth is like, okay, once a drug user, always a drug user. No. It's a traumatic experience to a patient, like to be heard that you are a drug user and you will always be a drug user. So it's very important to understand that situation. The more we are close to the patient, like explaining them, understanding the issues, okay, and encourage them. So it is more than the treatment we are offering. Approach to the patient, the communication, the tone, these are all very important. It tells indirectly the patient, okay, I'm there for you throughout this process. And then teenagers are too young to get addicted. No, age is not a concern, any age. So, and mainly these days the advertisers target young people. So no matter what the age is. So the few reasons why it's very common in teenagers, because there is a rise in the online alcohol delivery these days. And these online alcohol deliveries are unregulated services. And it increases the chances of like the youngsters at home becoming subject to alcohol dependence. And it normalizes the fact that AOD use in daily life. It also extends the heavy drinking occasions, because when you go out and have a drink with your friends, the time is limited. So but when it happens at home, so it extends the time. And then it's one of the quickest and easy way of accessing. So that also leads to dependence. So the young brains, particularly the prefrontal cortex, so which is responsible for decision making, is a growing brain, and the growth takes place until they reach their mid-20s. So this promotes the high risk behavior. And then, as we all are aware, the young mind, the young brain always wants to experiment on things. And so it helps to overcome their low self-esteem issues, and it helps them to feel good. It helps them to feel better, and it helps them to overcome their stress, their anxiety. So this recent study states, so when a person starts drinking at an early age, it is associated with the development of alcohol dependence later in their life. So a lot of studies have found it's important to address this issue, the addiction, at an early stage. So the doctors should identify their vulnerable patients at a very early stage. They shouldn't wait. They shouldn't delay time. So the other myth, the people need to experience downhill before they get better. So what does it mean? Does it mean that you should wait till they suffer the worst? No. So the reaching the bottom line, the rock bottom, is a subjective perception. what is the bottom line like? So it's very subjective. So for the person, it may be like at an early stage than we think. So it increases the patient's level of anxiety every time you delay the treatment. So it leads to loss of confidence in the treatment process. Another myth is that if they love me, they would stop using. What if the patient thinks, if we loved he or she, they would understand the real situation I'm in. Okay, so in summary, it's time to change the thoughts about our patients with addiction issues, because it's help us to manage them, guide them, and support them throughout their treatment process. And understanding the myths surrounding the alcohol and other drugs is critical to provide a non-judgmental management to our patients. And stereotyping AOD users can affect the treatment process and the follow-up. And it's very, very important to understand that AOD users are our community. They are not a set or bunch of people from another planet or somewhere else. It's our own family. So they are our own family, our friends, our community. So if we understand this concept, it's the treatment is like a simple thing for us. The power of words, and again, it's very important. And to introduce effective communication strategies. So even like the usage of words like addicts and like using terms like, okay, drug addiction or like a substance addiction could be detrimental. And it's important to understand that everyone can help reduce their stigma. So then they will come forward to access treatment. And the pathology behind addiction. So it's a drug-induced neuroplasticity. Thank you.